Welcome everyone to World Mental Health Day. So glad that you're here joining us today on this international acknowledgement, celebration, and heightening awareness around issues of mental health and wellness. We are so glad to join you. My name is Dr. Afiya and Billy Shaka, and
I am Dr. Chanda. It's so great to be here with you again, Dr. Afiya, and welcome to our guest. So happy to share this World Mental Health Day with you all.
Right. How y'all doing? Y'all real quiet in the chat right now. Can we get some love? Okay, we see you, Divine. Thank you for coming, and peace to you too.
Yes.
All right, Dr. Chanda, I'm going to get started with sharing the screen for our presentation because we have to be real formal. I like to be organized and into this official workshop webinar vibe.
Period. And while Dr. Afiya is pulling that up, let us know where you are joining us from, the city that you live in. I'm a little churchy, so we call it a talk back church. So I want y'all to talk back to us. We're not about to be quiet in here. So I want y'all to light the chat up and let us know where y'all are tuning in from.
All right. There, people are responding, Dr. Chanda, right? I know I go off of energy.
Me too. Hey, Baltimore. Hey, DC. We got Georgia.
Baltimore in the house. Okay, Hyattsville.
Yes.
All right. I used to live by PG Plaza Mall, so you know what I'm saying? Like, right across from the Home Depot.
Hey.
All right, Marietta, Georgia. That's where you live in Post Park? Okay, never mind. I'm not trying to give your address out to it. All right, so you all tapped in. You tapped in for this very special discussion. Let's talk Black girl depression. Dr. Chanda, do you feel like Black girl depression is a thing?
It's a real thing, Dr. Afiya, and I'm so happy that we're having this discussion because far too often we perpetuate this idea that we're not allowed to have emotion and we have to persevere. So I'm so happy that you allowed me to join you and we're able to join forces together to discuss this.
Yes. All right. So, Dr. Chanda, you're next.
Yes, so this is our mood meter, y'all. So I know we had y'all in the chat talking about where you're from, where you're located. I want you to put in the comment section what you are feeling. This is our official check-in. How are you feeling today? And I don't want to see anybody putting okay, all right, or any of those other general terms. Right now, I want us to practice what we call emotion identification skills. And so we're going to use this chart in order to identify how we're feeling, and we're going to check in with one another. So let us know, how are you feeling?
Maybe Dr. Chanda, you model it. Where are you on this chart? We got to model it first. We can't have people disclose without the model.
Period. So I would say I am feeling relaxed right now. I'm not going to lie, a little anxious. Dr. Afiya, it's around that tax extension season. So, I'm getting the taxes together for the tax person. And, that got me a little anxious. But other than that, I'm feeling mostly relaxed.
Okay. Yeah, I am feeling grateful. I have extreme gratitude for days that heighten awareness for mental health, since this is my love and passion and life mission. And I'm feeling a little tired, I need this rest day. So, all right, but I'm looking in the chat. Erin is feeling rested and optimistic. Dareth is feeling happy and content. Hey, Dareth. Lakia is feeling restful and content. Okay, we got some rested and contentful people at ease. Sheila's feeling, and Divine is hopeless and tired. All right, hopefully that we can monitor that. You want to weigh on that, Dr. Chanda?
Yeah, I love Divine. We definitely appreciate your transparency because, it definitely takes a lot of courage to be transparent about how we're feeling. And we're going to talk more about things that cause us to feel hopeless and tired and how that can be symptoms of other things that we'll be talking about today.
Absolutely. Yeah. All right, Adrian's satisfied. And Ladante is feeling relieved and calm, which is a blessing considering, oh, you just had a major surgery. Lots
Yes.
of vibes sent your way. Lots
Okay.
of healing vibes.
Yes, yes. Send that your way. Awesome.
Yeah,
Well, we appreciate y'all for checking in with us.
absolutely. Because we just had you go right away and talking about your feelings. But, you know, we're in good company. I think luckily talking about feelings and mental health has become more of a popular or a trending experience since the pandemic, my personal opinion. And there's been a lot of Black celebrities and especially Black women coming out about their struggles with depression, right? To identify that they explicitly were feeling depressed and how it looks differently, a little bit different in different people's lives. So for example, I'm sure y'all have heard of Taraji, but there are some times where I feel absolutely helpless, right? Absolutely helpless. Those are strong words and language to describe your feeling. Or, you know, Michelle Obama during the pandemic was very open about her mental health stressors, saying that I'm waking up in the middle of the night because I'm worried about something or there's a heaviness. So even hearing a past first lady talking about the heaviness and difficulty sleeping, or even Janet Jackson, that she really wasn't happy with how she looked. And for most of her life, she lacked happiness following her. So to even think about, like, this is someone who's been wealthy her whole life, has had basically anything she's wanted, but still feeling like she couldn't be happy. And even about how she looked, right? But couldn't feel like she could ever be happy. Does any of this sound familiar? I'm not trying to get in your business, but these might be thoughts that we've experienced or concerns that have come up. All right, Dr. Chanda, we're going to go through these learning objectives, right? Because it's always an opportunity to learn, and self-awareness is so critical. So we're going to guide you all through some of this cultural, historical aspects of understanding depression, right? Because we have to understand how we arrived to this moment in time as Black women. Hopefully there'll be a heightened sense of knowledge as we clarify some of the symptoms for common mood disorders, right? It's not just depression when someone feels depressed. There are multiple disorders that are connected to that low feeling. And then skills, hopefully we can recognize the differences in diagnosis and the role that culture can play, and even how our culture can factor in how we get treatment. There are so many different ways to treat depression, and so we're going to be going through that as well today. Does that sound good? You all ready for this? You have a notebook? You ready to ask questions? We're there? We're good? I know it's Monday afternoon. Okay, we're getting some thumbs up. All right, let's go. Okay, let's go. Right.
Yeah, so just to go a little bit more into detail about myself and Dr. Afiya and a bit of our backgrounds. So this just kind of gives a little snapshot into our careers. So we are both licensed clinical psychologists. About this work, we specialize in working with Black people and Black mental health, especially that of Black women. And here are the different networks and organizations and people that we've been able to contribute to. So like we said, mental health has become a very popular topic over the past few years, especially since the pandemic, and people are reaching out to us to try to get further clarification pertaining to Black people and our mental health. So just giving you all that background about us.
Okay, so Dr. Chanda, just wanted to put our receipts there to show that we're legit.
We know what we're talking about. I'm just trying to get the people to know we know what we're talking about.
You know, subject matter experts on Black women's mental health, you know.
Just not a major.
All right, so let's start with this. What makes something a psychological disorder, right? We have to enter into the conversation of what is healthy versus unhealthy, normal versus abnormal. And right here is basically a list of ways to understand what makes something a psychological disorder. So the first thing we can go over is dysfunction. Basically, it's something not working. It's something broken down in the way that we think, the way that we feel, and the way that we are behaving and acting. It's something not working, just like your phone might have some glitches or something going on with your refrigerator. Is something not working the way it's supposed to work? All right, another aspect of what determines if something is healthy, unhealthy in terms of psychological disorders is personal distress. Basically, do you not feel good about what's happening? Do you not feel good? Or even do other people feel distress around the way that you think, the way that you feel, or the way that you behave? It's something outside of that comfortable, this feels good zone. And then also acknowledging, is a certain behavior, thought, or feeling atypical, or is it not a culturally expected response? So I'm just going to give my PWI versus HBCU experience. So for undergrad, I went to the University of Pennsylvania, and there it was very normal, Dr. Chanda, when it was snowing, for people to wear shorts and flip-flops, right? Everybody was wearing shorts and flip-flops when it snowed. My classmates, I was not wearing the shorts and flip-flops when it snowed, but that was considered normal there. And I was abnormal because I had like a triple fat goose. Okay, I went to college a while ago, but had real big coat on, boots and all of that, but was seen out of context, right? That they were normal and I wasn't. But then I went to historically Black college. I went to Howard University for grad school, and it was the complete opposite. When it snowed on that campus, nobody even came outside, right? So classes were trying to get canceled. Nobody was showing up. If you came out in shorts and flip-flops there, you would actually be like, who is that over there? They need to go to the counseling center or something, because it was seen as just being so out of context. But I can give you this sort of cheat sheet of understanding mental illness, the 4 Ds. And I'm using mental illness very clearly on purpose to suggest that when someone's not feeling well, right? When someone's not feeling well. So we can think of it as this: deviance, distress, dysfunction, and danger. Those are 4 ways we can basically identify is something healthy or unhealthy when it comes to our thoughts, feelings, or behavior. So deviance. Deviance basically means, are you doing something that the average person doesn't do? And now it can even be the frequency of that behavior. All right, I'm just gonna pick something. During this pandemic, we know people have really been into washing their hands, right? People, that's a normal behavior we're all doing. I would love for you in the chat right now to ask about how many times a day do you think the average person washes their hands right now? Give me a number in the chat. The average number of times a day that someone is washing their hands. You could just put a little guesstimate in the chat, a number. Okay, Dr. Chanda says 4 to 5. What do other people say? I want to hear Divine, Adrian, LaDante, what do you think? Okay, we got a 10 from Sheila. We got a 6 from Dareth. Yeah, let's go with the 6. If I can do the average 6 times a day, right? That's for bathrooming, because you know, Dr. Chanda, not everybody be washing their hands. You've been in a public bathroom, they just walk out.
Just nasty.
All right, let's go. But okay, we're washing our hands for the bathroom. We wash our hands when we come in outside the house. We wash our hands for cooking, right? Maybe after a meal to clean our hands. All right, but there are going to be people who wash their hands, I'm looking at the chat, 8 times an hour, right? There's going to be somebody who's just going to keep washing their hands. Imagine what your hands would look like if you washed your hands 8 times in an hour, on the hour. So probably real dry and cracked. I don't even know if shea butter could repair that. But if you think about the opposite end, let's say that there are people out there who are washing their hands 6 to 8 times a year. Imagine what their hands look like, right? So even thinking about something as simple as hand washing, we can see on this spectrum. And so the people who are doing too much or too little, that's considered deviance. But I just want to use one more example, Dr. Chanda. Let's go with crying. I would love for in the chat, and this is, you know, this is your choice to participate. On average, how often do you think a Black woman cries per month? How many times do you think the average Black woman cries per month? All right, this is just okay. Dareth is saying like, okay, 10 times, so that's every 3 days. Okay, once or twice, Aaron said, you know, like maybe in the beginning of the month, the end of the month. All right, Sheila says maybe not at all to 1. All right, Divine's like 7. Once, basically have every 3-4 days. All right, Dante's like 5 times, like, okay, maybe once a week with the extra time. 30 times, okay, maybe once a day, Sincere says. All right, so we have to think there's a range, but let's go with, I'm going to calculate it. Let's go with 5. I'm trying to do quick math in my head. So let's say 5 times a month. But there are going to be Black women who are crying 5 times a day. And there are also going to be Black women who are crying 5 times in their entire lives. And I'm just going to give an example real quick, not to put my family's business out there, but I have this Aunt Carol, my dad's sister, who I have never seen cry. This woman does not cry. I remember going to my grandmother's funeral, she didn't cry. My grandfather's funeral, she didn't cry. Her husband's funeral, she did not cry. My cousin's funeral, her own daughter, sis, did not cry. And I had to ask my dad, I'm like, Dad, has Aunt Carol, have you ever seen her cry in your entire life? And he was like, I think once when she was like 12 and she got in trouble this one time, but that can even be seen like, that's really little crying. My aunt is 80 years old, just to give that context, and my dad's in his 70s. And so just to think not crying can also be a concern. So even think about what it is, but that cultural norm of what we think is average. All right, distress, like I shared for the 4 Ds, is you don't feel good about something or someone else doesn't feel good about a behavior. Dysfunction, again, something is broken or not working. And then danger. Yes, a certain thought, feeling, or behavior could actually be dangerous, right? If it causes harm to yourself or other people, it can be dangerous. So these 4 Ds are a way that I think of how to categorize a thought, feeling, or behavior as normal or abnormal. You agree, Dr. Chanda? Am I doing good? Okay, thank you, Dr. Chanda. All right, so the purpose of diagnosis, why do we even diagnose people? As clinical psychologists, why do Dr. Chanda and I diagnose people? Well, it helps us to communicate to each other around what symptoms someone has, right? If I'm saying someone's very tired and they're hungry all the time, maybe that could be they're pregnant, but it also could mean that they're feeling depressed, right? And so we have to group different things together. Also, a major purpose of a diagnosis is to get a treatment. So have you ever had to go to multiple doctors and get a second and third opinion, right? Basically, when you have a diagnosis, then it's, the best way to treat this is to do that. So I remember I broke my foot several years ago and had to get an x-ray, right? Once they said my 5th metatarsal was broken, they knew the best way to treat it. The same thing when it comes to mental health. Once we identify what is going on in someone's mind or their behaviors or their thought process, we can then treat it. And so, for example, I would love for you in the chat right now, what do you all do when someone has a cold? What's the best way to treat a cold? Because sometimes there's controversy in the chat around this one. What is the best way to treat a cold? I want to know your family secrets, your recipes. I want to know them. I want to try them. It might be a bad cold and flu. Okay, ginger ale. All right, that cures everything. All right, rest, fluid soup, rest and fluids. All right, so just the same thing. If we know it's a cold, we know how to treat it, right? Versus if it's some sort of virus, maybe those things will or won't work the same way. And so we have a book that we all use in the mental health field, or most of us, the Diagnostic and Statistical Manual of Mental Health. So the DSM, it's up to its 5th version, and it's developed by the American Psychiatric Association. So psychiatrists are mental health professionals who prescribe medication, right? The difference between a clinical psychologist like me and Dr. Chanda and a psychiatrist is that me and Dr. Chanda don't prescribe meds, but a psychiatrist is. So they're looking for chemical imbalances and all of that, but that's who actually made the book. So for a lot of the psychological disorders that exist in this DSM book, there's a medication that goes along with it too, right? And so this book contains all the listings and descriptions of various psychological diagnoses, again, for the purpose of coming up ways to identify and then to be able to treat it. But as you can imagine, it is extremely biased. So considering that the first DSM was made in 1952, imagine some of the social order and structure in the United States during 1952, right? The second version came out in 1968. 1968, things weren't even that great for Black people then too, right? Dr. King got assassinated. Think about it. These are the times when these psychological disorders are being developed. And so a lot of them are based on this implicit white male, wealthy, heterosexual client, right? So we said psychiatrists are in control of this book. And so they had someone in mind when developing these psychological disorders, right? That white, male, wealthy, heterosexual was healthy, and people who didn't fit within that could actually be seen as unhealthy. So I imagine, I don't want to project onto anybody in here. I'm imagining there's no one who identifies as these characteristics in the chat right now. I'm assuming that none of us are. So just to even think about how that there could be bias against us. But I want to get a little bit historical and understanding two psychological disorders that happened about 100 to 150 years ago that were very common for people who look like us. So one disorder that comes from one of the ancestors of mental health in this country is Dr. Samuel Cartwright. He proposed a psychological disorder called drapetomania. I don't know if you all have heard of this one before, but drapetomania was considered a mental illness for Black people, only Black people, if they had a desire to free from servitude. Yes, you could be diagnosed with a psychological disorder if you were an enslaved African on a plantation and wanted to be free. Dr. Chanda, I think I would have had this. I think I would have had it. But the desire to not be a slave was a psychological disorder. And one of the ways that they would actually prevent the disorder and treat it, it was the same way to prevent it and treat it, was to whip somebody, to whip them. That this was a way to not make them want to flee from servitude. And if they did, that was also the treatment. So again, I'm mindful of these diagnoses and treatments being very biased. And then there's something called hysteria, which was very popular at the birth of European Western psychology in the early 1900s. Hysteria was basically a psychological disorder if a woman expressed intense emotion, just was loud, was crying, had an attitude, a woman would be diagnosed with hysteria. And basically they identified the reason that a woman would be emotional would be that her uterus was moving around to different parts of her body. Her uterus was floating. She had a floating uterus, and therefore it made her very emotional. It made her very emotional. So to think about these two particular disorders, one that only Black people could be diagnosed with, and the other that only women could be diagnosed with. So imagine that intersection, Dr. Chanda, for the origin of some of these disorders that were Black women are the complete opposite of who was making some of these disorders. So they were using their norms and values to be able to diagnose us and to say we're sick. Are y'all paying attention to this? And I just want to make sure that we're getting the bias that exists in some behaviors that can be normal or healthy for us. And so even with that context, let's get into what these mood disorders are. If you're here with me, can you write in the chat, I'm ready? Can you write, I'm ready, if you're ready to go through these mood disorders? I got to know. All right, Dr. Shanda's ready. I got Adrian's ready. Aaron's ready. All right, Sheila is ready. Divine is ready. All right. Okay, Lakia, I knew you had to be ready too. All right. So do we know who this is in the picture? You know who this is? If you know who it is, write it in the chat. Write her name in the chat, because she is actually the highest paid female athlete in the world. She is the highest paid female athlete in the world. All right, Sincere, be careful while you're driving. Do we know who this is? All right, the highest paid female athlete right now is okay, Adrian got it, Naomi Osaka. Naomi Osaka has been very, very explicit that she has a mood disorder. She's told us. She's been in news interviews. She hasn't showed up to games. She's canceled major matches because her mind, she felt like, wasn't right. So let's get into what mood disorders actually include. All right, so mood disorders, if you have a mood disorder, your general emotional state or mood is distorted or inconsistent with your circumstances, and it interferes with your ability to function. Basically what this means, again, going back to those 4 Ds, something is not working. You may feel extremely sad, empty, or irritable, or you might have periods of depression, altering alternating between being extremely happy and extremely depressed. And so when somebody says mood disorders, it can include any of the following: major depressive disorder, bipolar disorder, cyclothymic disorder, seasonal affective disorder. I feel like you all have heard of this one. We're going to go through it because the way this weather is changing. All right, depression related to medical illness, right? To think about, what does a diagnosis of cancer do to someone's mood? Or something called dysthymia, or a persistent depressive disorder, meaning that someone can have the symptoms for years. And then premenstrual dysphoric disorder. This is one of the newest mood disorders, PMDD. And guess what? Only women can be diagnosed with this disorder. And it lines up with moods changing during your period. So we're going to get into that. All right, y'all ready? Okay. Shameless plug, Dr. Chanda. Can I shameless plug? This is my book. It's all about depression. All about depression. You see my name on the bottom, second row to the right. So this book actually was written by all Black psychologists. It was written by all Black psychologists. Picture that, a book all about depression written by all Black psychologists. You know, it's an ebook, you can pick it up. Kendall Hunt. Okay, but let's get into some bullet pointed facts. So depression is one of the most common mental disorders in the world. Globally, more than 264 million people of all ages suffer from depression. And so it's actually the leading cause of disability worldwide, and a major contributor to the overall global burden of the disease. And it's bolded right here: more women report, and I should add that in there, report being affected by depression than men. I would love for you in the chat right now, why do you think more women might have a diagnosis of depression? I know we didn't even get into the full symptoms of depression, but you could still add and guess. Why do you think more women might be on here? Why are more women having a diagnosis? All right, women tend to vocalize feelings more. Excellent point, right? We seek help. Exactly, Dareth. So I saw some comedians say, like, a man's prostate will fall out of his butt and he'll tape it back in with some duct tape, right? Just not even putting the attention that, yeah, men do not seek help. So even thinking about this, that there's disparities in the numbers of women versus men who have the diagnosis of a depressive disorder, but women tend to get treatment more. We also need to recognize that depression does have a relationship with suicide ideation and even suicide. But also what I hope you take away from this slide is that there are effective treatments for depression that are both psychological and pharmacological, meaning medication, and that it can treat very moderate or severe forms of depression. All right, and then Dr. Chanda, can I show a quick clip? All right. So does anybody like the show New Father Chronicles? It might just be me. I like to watch it on YouTube. It's about a dad and his two daughters, but his wife is in and out of the videos. And so sometimes she's out of the videos because she's actually having severe forms of depression. And so this is a video to describe what her depression feels like. Yes, Erin, you follow? Yeah, LaGuardia. Such a great couple. Yes, and very open about her mental illness. So I'm going to play this clip really quickly, okay?
Now, the most common comment I'm used to seeing is, how is Leah doing? Anybody that has been following this channel for any significant amount of time, you all know about some of the behind the scenes struggles we've had as a family. And so this may be the easiest sponsorship we've done, because Google set up something to help new moms dealing with postpartum depression, which is exactly what Leah dealt with for both of her pregnancies.
It was just incredible to have like this other little being, this tiny little baby home with us. And we were just excited. Like everything was just like, look at her. And you know, LaGuardia had the camera out. He was just, you know, so amazed in his own way. So his way is like having the camera in her face. And that's when he started New Father Chronicles. So that was just like, you know, it was just out of pure love and fascination over, wow, we made a baby together. Amala was maybe a month old when I started having these feelings. Her cry, like it was really hard to hear her cry. It made me feel panicky because she was colicky at the time. She would cry nonstop, no matter what we did. We tried all kinds of things. We went to the pediatrician. They had us trying all kinds of things, and I just couldn't take it. And I was feeling weird because my emotions would go from like panicking, like in distress, like because my baby's in distress and I'm not able to comfort her, to like frustration because there's nothing I'm able to do to like help her. And I felt bad because it was just like, so you're allowed to be gifted with a child and you can't even take care of her and she's not even asking much from you. It just made me like feel like less than a person. I felt like scum because I wanted her and then I wanted to give her back. And I didn't feel like a mom. I didn't even feel like a woman. I felt like I cheated, like being allowed to like give birth to a healthy baby because I couldn't take care of her and I didn't know what to do except for wanting to retreat and hide. I distinctly remember her being about 10 weeks. And, you know, LaGuardia was there the whole time, you know, witnessing everything, you know, hearing me, you know, cry and, you know, just being depressed. And I just didn't see it enough to be like, you know, I need help. It was.
All right. That was intense, you all. I'm going to stop sharing just for a second to see if anyone wanted to unmute and give a response. I know that could be quite triggering, but if anyone wanted to give a reflection on something that they observed or noticed or identified with, I just wanted to create safe space to do that. Is that okay, Dr. Chanda? Just to see if there was anyone's reaction to what was being shared. If you knew anyone who's gone through postpartum, maybe you've experienced it yourself. Sometimes it's called the baby blues. No pressure. I don't want to force anybody to talk, but I just wanted to create space because I know that was a lot to observe and witness, especially someone who looks like us. Okay. All right, I'm going to keep going, Dr. Chanda. Does that sound fair? Okay. All right. Okay. And so now I'm going through the symptoms of a depressive episode. And so what can happen with this to remember what the symptoms are is something called Siggy caps, a way to remember what the symptoms are. First, we can go through sleep changes. When someone's having a depressive episode, their sleep increases during the day or can be decreased sleep at night. So some people tend to sleep more when they're feeling depressed and some people tend to sleep less. In the chat, I would love for you, if you feel comfortable saying, when you're feeling really overwhelmed, sad, or distressed, do you tend to sleep more or less? Dr. Chanda, do you want to disclose what you do? Are you a sleeper or do you lose sleep when a lot's on your mind?
Yeah, so when it depends on the emotion. If I'm sad, then I'm usually getting more sleep. If I'm like anxious or stressed, then I get less sleep.
Okay, yeah. We got less sleep in here, a few people saying less. All right, and then a loss of interest in things that usually would cause you pleasure. So if you love to dance, you love to sing, you notice you're not singing and dancing as much, or maybe you love to write and paint and you're not doing those activities, or even you love to run like Dr. Chanda. I'm trying to keep up with Dr. Chanda, but not even wanting to run or do it anymore. All right, another one is guilt or a sense of worthlessness. So depressed people tend to devalue themselves, put their own selves down, have negative self-talk. Oh, why do I look like this? Why do I act like this? I'm such a loser. That's something that could echo through someone's head. And then energy, so a lack of energy, oftentimes presenting as fatigue. I've seen memes out there saying when a Black woman says she's tired, believe her, right? In terms of recognizing that it's a deep level of fatigue, not that they miss a night of sleep, but like just exhausted to their bones. All right, C for CAPS. So cognition and concentration. Do you have a reduced ability to think or focus? Are you having difficulty concentrating, tending to maybe have to read the same line over and over in an email, or getting overwhelmed with tasks for work or school where you can't seem to complete assignments or turn things in on time? Appetite. All right, this can be a weight change when you're not intentionally trying to lose weight. So that could be either you eat more or you lose your appetite. All right, if you want to disclose in here, who in here tends to eat more when they're feeling sad? All right, me. All right, who tends to eat less? Anybody lose their appetite? Please let me know. Do you eat more? Okay, Sheila said, I eat more. Adrian's less. Dr. Chanda less. Okay, see, more. Yes, Pam. Right, Pam. I have this, I cannot be satisfied when I'm sad. I'm like, ooh, that cake looks good. Oh, that brownie, it tends to be sweets for me. But I know my husband has a complete opposite thing, that he turns into very thin and bony person when he's having significant amount of stress. Me, I get real cushiony. Astrologically, eaters during these times may have Cancer in their chart. Okay, data. It's what I eat, junk food and pastries. Yeah, so it's not like eating lots of strawberries. It tends to be bread and cookies. I know the carb loading happens for me. All right, and then psychomotor. So you actually tend to move your body differently, being more agitated and feeling more anxious, or even slowing down. You're just not moving fast. Your body is like, oh, let me get up out of this bed. Oh, let me go take my shower. Oh, that took 2 hours to get out of bed and take a shower. That actually can be a sign or symptom of a depressive episode. And then finally, suicide or death preoccupation. So having lots of thoughts of ending your life. It could just be a thought, right? But what would things be like if I no longer had this pain, or if I wasn't around? So that actually can be a symptom of a depressive episode. And so you might say, well, what triggers this? What is causing this to happen? Right? What is causing this to happen? Well, it could be chemicals. There are neurotransmitters. These are chemicals in your brain that regulate your mood, or pleasure, or body homeostasis. So things like dopamine, norepinephrine, or serotonin. There's a medication specifically called SSRI, selective serotonin reuptake inhibitor, selective serotonin reuptake inhibitor. And these medications regulate the amount of serotonin, which is connected to depressive episodes. It could be genetics in terms of twin studies, and family studies suggest that genes play a role. So if your mother had depression, you're 50% more likely to have a depressive episode at some point in your life. It could be situational in terms of very stressful life events, such as a death or loss in your family, losing your job, having a breakup, a divorce, losing a child. All of these different factors playing into causing or triggering depression. Another thing is cognitions. Dr. Chanda is going to go into this in depth in terms of the way that we think, our approach or mindset to things. And then finally, oppression. Thinking about us being Black women, there are a lot of circumstances in life that we're taught we're ineffective, we don't have control. There was basically a study done by someone named Seligman, and he locked up these dogs in a cage and then opened up the door cage. And if the dog tried to escape, it would get electrocuted. So it would try to escape and get electrocuted. It tried to escape and get electrocuted. So to the point where the dog's like, I'm not trying to get out of this cage, I'm going to get electrocuted. So what did the researcher do? They turn off the electricity, and regardless of if there was electricity or not, the dog never tried to escape. Now, there's a very famous psychologist named Dr. Amos Wilson. He's now an ancestor. But Dr. Amos Wilson said we shouldn't identify with the researcher. We should identify with the animal. To what degree are our lives being controlled in this way, that regardless of what we feel like we could do, that someone else is controlling? And so there's this learned helplessness. I won't even try to get free. I won't even try to lose weight. I won't even try to go on a date. I won't even try to get this new job, because in the past when it happened, I didn't get it and it was terrible. So how does that get generalized to future experiences? Yep, Element remembers those studies. All right, so there are so many different types of mood disorders that have depressive episodes. So major depressive disorder is probably one of the most common out there, and it has to have those symptoms that I went over for just 2 weeks. 2 weeks of having it. Oftentimes it's recurrent. So if you have one depressive episode, it's more likely that you'll have them more in the future. Or there's something called dysthymia, where it's a less severe form of depression, but it happens for years. To get the diagnosis of this, you have depression for years, and it's higher frequencies for Black women in particular, that we're like, well, has become the norm, right? All those symptoms I described. Or seasonal affective disorder. So these are cycles by sunlight. It's similar to hibernation, that when that winter weather comes and we get more and more depressed, there's less sun, and less sun in the mornings in particular, which has a huge impact on our ability to start the day. All right, I talked about this earlier, PMDD, premenstrual dysphoric disorder. This basically is when someone feels irritable, overly sensitive, they're crying, they're forgetful, have arguments, and it all relates to having their menstrual cycle, either the week before or the week of. These symptoms emerge. When they're not having their period, the symptoms are gone. Bipolar disorder is something similar in terms of having depression, but it's also followed by a more manic episode, which I'll get into, and then postpartum depression that Leah in the video had, where there are hormonal shifts and even that sense of social isolation that comes with being a new mom, right? There's this unique cocktail that actually brings someone to these deep states of depression. Dr. Chanda, I'm gonna stop talking here, but in terms of getting into a manic episode is almost the opposite of depressive episode. And so to be able to tap into being more talkative, having all these ideas, not needing sleep, but we don't always recognize that we can have both. And that's the criteria for bipolar disorder, to have depressive episodes and these experiences of mania. All right, Dr. Chanda, I'm gonna stop talking and let you go now.
Listen, Doc, we appreciate you for giving us the rundown of depression, mood disorders, all those things. I want y'all to put a fire emoji or a 100 emoji inside of the chat section if you have been learning from Dr. Afiya and some of the things that she had taught us. So we're going to go into some more of the causes and what we call the maintenance factors of depression. And what we mean by maintenance factors is basically what maintains these symptoms. One of these things are called cognitive distortions, basically how we think. So before I get into, somebody put the 100 emoji. Okay, keep lighting the chat up. So before I get into cognitive distortions and what they are and examples of them, I want us to look at this picture that I have on the left side of the screen. And I want you to put in the chat what exactly you think this is. How do you interpret this picture? And I'm sure we've seen this before. This is called an optical illusion. So what do y'all see? Dr. Afiya, what do you see?
Okay, the first thing I saw was a young woman.
Okay, so you see a young woman. Element sees a young lady as well. Lakia sees two things, so a young woman as well as an old woman. Sheila sees a young woman. Yeah, so I love that y'all are engaging in this. So when I initially looked at this, I saw the young woman with her head turned, and this is a very common optical illusion. You can actually Google it. And then I also saw the older woman, where it looks like here is her, I don't know if y'all can see my mouse, but her nose is the chin of the younger woman, and you can see her mouth at the bottom area. And so why are we looking at optical illusions? Well, it's basically showing us how our brains are essentially wired to make interpretations. Our brain is wired to fill in the gaps, because in split moments or moments where I have to make a quick decision, I might not always have time to observe every single detail. So our brains are wired to fill in the blanks and to make interpretations. However, the problem is sometimes the interpretations that we make are based on not necessarily taking in the full picture, not taking in the full idea of things. And sometimes when that is negative and it impacts our mood, we label that as a cognitive distortion. So just like optical illusions, cognitive distortions trick you into seeing something different to reality, or at least an incomplete picture. And so we're going to go over a few cognitive distortions and what they look like. Okay, so here's an example of more cognitive distortion. So again, basically how I define cognitive distortions is taking the word distortion, something that is twisted, not based in reality. And when we say cognitive, we're basically talking about thoughts. So think of a cognitive distortion as a twisted way of thinking. It's, again, not rooted in reality or not taking in the totality of the situation. One of the most common cognitive distortions that we tend to utilize, especially me, Dr. Afiya, people think that, as psychologists or whatever, sometimes we don't experience these, but everybody has these. One of the most common ones is dichotomous thinking. And so dichotomous thinking is also known as black and white thinking. For instance, we're not seeing ourselves, other people, or the world in terms of gray. We're not taking in the whole picture. It's either all good or it's all bad. I'm either 100% perfect or I'm a failure. I didn't get the job, therefore I'm a terrible human being. I'm incompetent, right? So there's no gray area at all. So when we think in these dichotomous ways, why is that bad? Well, we're not giving ourselves room for error. We're not giving ourselves room to be human. Therefore, thinking dichotomously causes us to either see ourselves as either 100% good and 100% bad, and that can negatively impact our mood. Another cognitive distortion that is very common is disqualifying the positive. Disqualifying the positive. So not counting the good things that have happened, only focusing on the bad. So one example that comes to mind for me is, imagine you did a presentation at work, your supervisor gave you amazing feedback, your colleagues gave you feedback, and then that one person says, oh, you could have did better on your slides, or you could have added more pictures to your slides, or you had a typo in slide 3. I just want you to be aware of that. And so disqualifying the positive would be for me to completely negate everything that all the good things that people have said about it, and to only focus on that typo that I put in there, to only focus on that time that I stuttered, to only focus on the things that aren't necessarily positive, that make me feel good about the situation. I'm disqualifying the positive and only focusing on the negative. And when we think that way, that has a tendency to exacerbate what we call negative moods, and can again lead to that depressive cycle that we're talking about. So what are y'all saying in the chat? Somebody said, Lakia said, I tend to disqualify the positive all the time. Lakia, girl, you are not alone. And so I want you to know that. So Dr. Afiya says you do that. I do that one. So are you talking about dichotomous thinking, Dr. Afiya? I feel like that's probably the ones that I use the most often as well. And so like we said, it doesn't mean that there's something wrong with you, that we are disqualifying the positive, Dr. Afiya says. It just means that we have to pay attention. We have to think about the way we think, right? So I know that sounds weird, but we really have to think about the way we think. All right, so another form of cognitive distortions is jumping to conclusions. Jumping to conclusions. Y'all, I'm not gonna lie, I jump to conclusions every day. Like what, jumping to conclusions is probably part of the ways that we protect ourselves from harm. Again, it's our brain's way of filling in blanks, but it's not okay if it's causing me to, it's causing exacerbation in symptoms, or exacerbating negative feelings and negative thoughts about myself. So one common example of jumping to conclusions is what we call mind reading. So mind reading is me assuming that I know what other people are thinking about me. So for instance, let's say you're texting one of your good friends and they all of a sudden stop texting, you don't hear from them for a few hours. Mind reading would be, oh, they thought the conversation was boring, or I must be a burden to them. I must be wearing them down. Mind reading suggests that I know exactly what's going on in that person and their lives, and I'm trying to interpret what that means in my situation. So Sheila girl said that that's her. So Sheila, listen, I know it's relatable to all of us. Erin said that that's her as well. Y'all, that's probably, again, one of the very common ones that I come across. Fortune telling, that is another common method of jumping to conclusions, fortune telling. So that is basically where I assume that I know what the outcome is going to be. I can't have that conversation with my supervisor. I can't ask them for a raise. Why? Because they're going to say no. I can't ask that person on a date. Why? Because they're probably already dating someone, right? So jumping to conclusions means that, again, I'm allowing my brain to kind of jump to these arbitrary conclusions without any set evidence, which inherently can cause me to go into some sort of like anxiety spiral, or to experience a depressive mood. I love that y'all are relating to this. All right, so we got some more cognitive distortions on the way. So we have catastrophizing. Catastrophizing. So catastrophizing is basically when we're thinking that the worst case scenario will be the likely outcome. The worst case scenario will be the likely outcome. So what do you mean? So that is me thinking that if I go on this job interview, they'll probably say I won't get the job because I don't have enough experience. So I'm thinking about the worst case scenario and assuming that that's going to happen. That is catastrophizing. Or if I try to walk across the street, then I'll likely get hit by a car, right? So always thinking the worst case scenario, blowing things pretty much out of proportion. And so you'll find as we talk about these cognitive distortions and we think about what they mean and how they show up in our lives, that a lot of them overlap. So if I have a thought that's catastrophizing, it might also be jumping to conclusions or dichotomous thinking. So they usually tend to overlap. So it's important to keep that in mind. And then we have should statements. So I'm pretty sure we have all used should statements. Should statements are basically when we say things like should or always or shouldn't or what have you, pertaining to ourselves, other people, or the world. I should be furthering my career. I shouldn't let that bother me as much. I should do this. I should do that. And when we give ourselves, when we think in the form of a should, we're not necessarily giving ourselves, again, that room to be human. We're putting a lot of expectations on ourselves, which can lead to intense frustration. It can lead to negative self-esteem or causing us to question our self-worth or where we are in terms of life and career and things of that nature. So are we shoulding? Are we identifying thoughts that can be formulated in a should statement? Therefore, we should be paying attention to that. So Dr. Afiya said, don't should yourself. I agree, Dr. Afiya, we should not be shoulding. Element said, could this thinking either be a result of high cortisol levels or the beginning to enter the system increasingly as thought develops catastrophizing? I'm not sure if I understand the question. Hold on. Could this thinking either be a result of high cortisol levels or are the beginning to enter the system? Yeah, so the HPA axis that Dr. Afiya is talking about is related to anxiety, which is related to also cortisol release. I'm not sure exactly how that impacts thinking or what have you. Dr. Afiya, if you understand the question, you can come in and hop in and answer that as well.
This is a high level question. It makes me think about the HPA axis, the hypothalamus, pituitary, adrenal connection in terms of how stress hormones function and are distributed throughout our body and how much our minds control it, right? The hypothalamus is something that is a like almond size, sorry, I came outside trying to get some sun, an almond size part of our brain. Our pituitary gland connects to it and it's a chickpea size. I think I'm hungry, Dr. Chanda. I'm just talking about vegan foods. Chickpea size part of our brain that then connects to a lower part of our body and like how it, again, communicates. Once we have a thought, our whole emotional, energetic stress level can shift. So when you have a cognitive distortion, it actually changes the chemistry of your body. So I think that's what Element's getting to, which is a really deep metaphysical concept. So keep going with it. Keep going, Dr. Chanda.
Yeah, no, I totally agree, Dr. Afiya. And it makes you wonder, like, does the cortisol, does the thought impact the cortisol, which I know we learned that it does, but also like, does the cortisol impact the thoughts as well? Which is, yeah. So I don't know, just something to think about. Okay, so when talking about personalization, so we're blaming ourselves or taking responsibility for something that wasn't completely your fault. So we often see this in people who experience trauma. Sometimes people who experience trauma in some way begin to self-blame and to target themselves and say it was my fault, or I could have done something differently to cause the outcome to be different. When in fact, it could have been several different things that could have caused the situation to go the way it did. So personalization, again, can lead to that negative way of viewing ourselves, other people, and the world. So it sounds like we have a lot of people in the chat who relate to some of these cognitive distortions that we tend to utilize. These are only 6, but there are tons of cognitive distortions out there that are very, very common. Yeah. And so here are some common forms of treatment. So I know we talked a lot about like depression, what causes depression, what maintains depression, all these different things. And so we want to be able to leave off on a happier note, like, okay, there is help out there. There are treatments that are proven and that have been tested and research that can really help people in order to help manage the depressive symptoms, especially Black women. So one of the types of treatment we call is CBT, cognitive behavioral therapy. So as I stated earlier, cognitive basically means thinking. And so we are focusing on this specific type of therapeutic modality. We're focused on our thought patterns. We're identifying those cognitive distortions, and we're learning how to deconstruct and restructure them. We're also looking at the behavioral aspect. So why would behavioral aspects be important in terms of depression? Well, think about it. You know, we talked about how depression can be a result of lacking serotonin and dopamine, norepinephrine, you know, all those different things that are highly correlated with like behaviors and activity and such. So when we change our behavior, when we start to incorporate behavioral activation is what we call it inside of the treatment plan, then we're able to target depression from a two-pronged approach where we're looking at cognitions as well as targeting behaviors. Narrative therapy is, you know, I think this is Dr. Afiya's lane, but we're focusing on values exploration and skillfully helping clients to identify their own strengths and looking at what that means. So we're identifying our own narrative and basically giving ourselves permission to rewrite our story. Dr. Afiya, did I explain that well enough? Awesome. And then we have interpersonal therapy. So this is basically when the depression treatment helps you to focus on interpersonal conflict, where you might be experiencing that results in depression. So if someone is depressed as a result of friendships or relationships or family dynamics or what have you, we would go about treatment in that same way, focusing on the relational aspect. And the idea is that depressive symptoms will begin to reduce and to be mitigated once we focus on the interpersonal functioning of that person. We can go to the next slide. All right, so there are different styles of therapy as well. Dr. Afiya, I must say we got some good pictures in here. I just love all the Black women pictures in our presentation. All right, so we have individual therapy as one style of therapy. So this is probably one of the most common styles of therapy. When we see therapy on TV, strong likelihood that you'll see the client laying on the couch or sitting on the couch talking to a therapist or a psychologist or whoever, and they're on that one-on-one type of dynamic, that one-on-one basis, and they're basically kind of working through things individually, working on things from that very targeted specific angle. However, there can be some limitations to individual therapy. Molly had some interesting individual sessions on Insecure. That is so true, Dr. Afiya. And so some of the limitations though to individual therapy is some people may struggle with focusing on their own thoughts and emotions in a one-to-one setting. I don't know if anyone here has ever experienced individual therapy, but sometimes it can feel really, really intimidating. It can feel intense when you're the target of the session, not being targeted, but when you're the main focus of the session and you're talking about your thoughts, your emotions, and sometimes it can feel overwhelming. And also there is less opportunity to see others going through similar problems. So I'm less likely going to be able to hear from my friend, Afiya, who might be going through similar situations. Why? Because I'm meeting individually with Dr. So-and-so. And so that is why we often talk about and we promote group therapy for especially Black women, people of African descent, us healing together. Dr. Afiya always says we do not heal in isolation. So group therapy is beneficial because there is more opportunity to connect with Black women who have similar experiences. And the group therapy space is a microcosm of society. And so that's actually a concept taken from, I believe it was Yalom. So Yalom talked about how he's a psychologist who talks about how when you're in a group therapy setting, it's basically representative of how you show up in the world. And so I don't know if y'all watch, shows, y'all don't judge me, but I like 50 Cent's little series that he has on Stars. So in Raising Kanan is what it's called. Raising Kanan, one of the actors they're involved in group therapy. They have to go to group therapy every single week. And I love how they highlight and how to bring out how Marvin is his name. Marvin is showing up in the group exactly how he shows up in the world. So the same level of anger that he experiences with other people, with like the fighting and the killing, he shows up in group that way. And he's able to kind of work through his anger in the group setting and actually take that same level of anger or same strategies that he has for anger to the outside world. And it's helping him with his communication with his daughter. I hope I'm not spoiling it for y'all. I was just up last night catching up on that show in so many different other areas. So that's just an example of how group is a microcosm. You can work on things in the group setting and also take that information into the real world. All right, so again, this is why we offer group therapy for Black women. Dr. Afiya, this is our third cohort, right? I believe this is our third one and fourth. Okay, so this is our fourth cohort, y'all. And so I have seen so much growth and progress in some of the women that we've been able to. Sincere said they love that show. I love it too. So many women who are able to benefit from the group. Dr. Afiya, what would you say are some of your favorite things that we discussed or talked about in group?
Okay, it's a hard one because there are so many relevant topics that I'm like, oh, they're going through that too. I'm even going through that in terms of thinking about just how to manage work-life balance, stress. And of course, we can't disclose what happens in the group because what happens in the group stays in the group. So it's hard for me to even give highlights. But just like the magic that happens when Black women show up for each other, regardless of what the issue is. I think our last group really had a mother theme to it. People negotiating how to protect their children in the society that's so aggressive and oppressive. And just even how to like stay healthy. This isn't right, that it is a process to achieve health and balance and all of that. So that's my way in.
Yeah, and you know, Dr. Afiya, so the fact that you brought up the common themes associated here, right? So like the common theme of motherhood, the theme of allowing yourself to be a mother and also to be a human, right? There are certain things that we can only get and experience as Black mothers as opposed to like being in a, you know, a more, I guess, I don't know, a white group or a group that's not centered around Black women. And so that's what makes this group so unique. And also, Dr. Afiya, even thinking about like how we make it so relatable, I think that Black women are able to relate to the group because they're able to relate to us. Like it's so many times, Dr. Afiya, where you would make a reference to like, you know, set it off or make a reference to some other Black thing. We talked about hair before, like so many things I feel as though makes Black women feel seen in our group. And that also helps to facilitate the therapeutic and the healing process. And so it is a group that allows us to focus on our three objectives. And one is to learn how to process emotions and past experiences, to experience vulnerability without self-imposed guilt. Well, why is this important? So one of the things that I feel as though hinders us as Black women from being able to really show up as our authentic selves is that fear of judgment, fear of being seen as weak, fear of vulnerability, that fear of, again, being judged, right? Being seen as less than because we might express emotions, or being seen as too much, or being angry because we do express intense emotion. And so we give our women the space to be vulnerable without feeling guilty. Hopefully they'll learn those skills and practices and show up in their families and in the world with them. And to also learn and practice new methods of communicating with others in order to improve functional relationships. I love our group, Dr. Afiya, because it allows us to be able to, again, like show up in the group setting, but also receive feedback from group members about how we're showing up, receive feedback regarding alternative perspectives. And, you know, Dr. Afiya, I think one thing that makes our group very different from other groups is because, again, there are two psychologists, two highly trained licensed clinical psychologists facilitating it, but also I more so am highly trained in CBT, and Dr. Afiya more so has that narrative therapy approach. So we're both coming at our group members into our groups with like these two different therapeutic modalities that we're both highly trained in. offering different perspectives from those angles, which again can be so powerful in those moments and help to facilitate that healing process. Yeah, so Dr. Afiya, let me know if you have anything else that you want to say about our group.
Yeah, it's hard again, because I can't say too much without giving away. How do you talk about something that's so amazing, but private and confidential?
Yeah.
So just the fact that we like doing it so much should be indicative of how powerful the group is. That again, there's such a parallel process as we relate to each other, and how that impacts the group dynamic too.
I love it. I love it, Doc. So here are just a few details of our group. So we do meet on Wednesdays from 7 to 8:30. There are only 10 spots and it's 10 virtual sessions, and we do have free consultations available. And Dr. Afiya, do you have times for those consultations already?
I do. I'm about to put my personal calendar in the chat.
Okay.
So people could just click it. So give me a second, because let me just put my stuff in there.
You're good. You're good. So at this time, we would like to open the floor for like questions or any dialogue that you all may have for the few minutes that we have left.